My name's Dr. Gill, and I've been asked to do an examination of your chest, looking at your lungs today. Is that okay?
Yeah.
Good evening, ladies and gentlemen. So this is a continuation of the respiratory clinical examination as read from Macleod's clinical examination by Elsevier. If you're listening to this on YouTube, then there should be a dialog box popping up now to let you connect to that earlier audiobook/podcast thing where we go over all the crucial questions to ask and the information you need to gather during a respiratory examination. Let's not forget that we're highlighting that 90% of your diagnosis comes from your history, as opposed to about 10% which is coming from your examination. The examination is still very, very important, as it is able to highlight and identify features which might not be expected on the patient and might help to shift your diagnosis, but the vast majority of the time your examination is merely there to confirm your suspected differentials that you've managed to come to by talking to the patient. One of the reasons I've decided to do things this way is that people have asked for additional information from the clinical skills examination videos that we've already published. Those examinations have been conducted so that they can be used in teaching in various ways and allowing the lecturer to talk over those videos. So that's actually kind of what we're going to do here today. Hopefully, we're going to take snippets from the existing examinations and then talk about and explain why particular tests are being done, and expanding to what the clinical sign is we may be looking for or have found, and what that can mean for both the pathological processes underlying the sign and how this can help us refine our differential. I must admit, in the respiratory examination there is several of my favourite clinical signs because they give you a really good, clear example of the underlying science that has gone into providing us with these clinical pearls, for want of a better word. Okay, with that in mind, let's begin the respiratory examination, the physical examination. During the physical examination, the patient should be reclining on an examination couch or bed at 45 degrees, with the thorax exposed and the head supported by the pillow. Now immediately people are going to compare with the clinical examination we've done and say, well, hold on, this chap is still fully dressed and you're looking at his hands to start off with. Whilst technically the patient should be fully exposed with regard to the thorax right through the examination, we also need to think about patient dignity. Does the patient really need to be exposed when you start the examination and you're having a look at their hands, checking their pulse and looking at their blood pressure? Probably not. And one of the ways that I tweak my clinical examination, as is seen here, is I examine the patient from the end of the bed at the start of the examination, commenting about any paraphernalia, so respiratory inhalers, if there's any evidence of medication, if there are oxygen cylinders and things such as that, before repeating the end of the bed examination after I've done the peripheral checks and I get the patient to expose their chest. Much can be learned about the respiratory system by careful inspection from the end of the bed. The normal shape and respiratory movements of the chest wall are significantly altered by the hyperinflation that accompanies chronic airflow obstruction. Such obstruction causes prolonged expiration relative to inspiration and sometimes pursed lip breathing on expiration. Forceful inspiration at these very high lung volumes may cause indrawing of the intercostal spaces during mid-inspiration and also the recruitment of muscles not normally involved in breathing. These are termed the accessory muscles. These include the sternocleidomastoid muscles involved in lifting the sternum and the trapezius and scalene muscles involved in lifting the shoulder girdle. Sometimes patients sit forwards and brace their arms on the table, allowing them to use pectoralis major muscle to pull the ribs outwards during inspiration. Due to the position in which the patient sits during this form of respiration, this is termed tripoding. In contrast to hyperinflation of obstructive airway disease, interstitial lung disease causes small, stiff lungs, diminishing the thoracic volume and may raise the respiratory resting rate. Chest deformities may be congenital, such as Pectus excavatum, or acquired, such as Pectus carinatum. The former, coming from the Latin for excavated or to be dug out, shows a sunken chest where the chest wall literally appears to have an indent within it. The latter, Pectus carinatum, is an inward displacement of the lower ribs with a prominent sternum caused by severe airflow obstruction in early childhood when the rib cage is developing. Interestingly enough, Pectus carinatum is also termed a pigeon chest because of the prominence of the breastbone, as would be seen in birds of flight. However, carinatum is actually from the Latin keel, which is the bottom of a boat that cuts through the water. And if you compare the images here of a Pectus carinatum and the shape of the bottom of a boat, you can see where the terminology has come from. Asymmetry of the chest may be secondary to scoliosis, shrinking of scarred lungs following tuberculosis infections, or prior surgical resection of a lung and/or the ribs. It is one thing to be able to perform the component parts of a clinical examination, but the order or sequence of how you inspect the patient is very important. As a result of this, we will start off with the examination sequence. Most medical examinations follow the protocol of inspection, palpation, percussion, and auscultation. Simply looking at the patient, poking the patient, tapping the patient, and listening to the patient with your stethoscope. By comparison, many of the surgical examinations have a somewhat simpler approach with look, feel, and move. As mentioned previously, the start of your examination is about using your eyes, looking at the patient, and checking their surroundings. When doing so, note the presence of nebulizers or inhalers, which might indicate chronic obstructive lung disease or asthma. Examine for oxygen therapy and cyanosis, and check for sputum pots, both for their presence and, as unpleasant as it may be, their contents. Look for asymmetry of the chest, deformities, operative scars, and chest drains, remembering that a thoracotomy scar may only be visible on the lateral and posterior aspects of the chest. So, as well as examining the patient as an overview with their clothes on, and from the front after they have removed their shirt, you should also do a similar inspection from the patient from behind. Quietly observe the time and respiratory rate of the patient, for example, counting the number of breaths in 15 seconds and multiplying by 4. This should ideally be done without drawing the patient's attention to it, as this may cause a change in the patient's breathing. If you wanted to, you could describe this as a medical example of the Heisenberg uncertainty principle, i.e., whatever it is you study, you also change. So if a patient is aware of you looking and focusing on their breathing, they tend to become self-conscious of that and breathe in a different or unnatural way for them. I find the best way to actually assess a patient's breathing is when you're taking the pulse. So you hold onto their wrist, count their pulse, but then continue on to listen to their breathing, at which point you can do the same maths, so count the number of breaths over 15 seconds, multiply by 4, and that is likely to give you a true respiratory rate without the patient being cognizant of how it is that you're assessing them at that moment in time. At rest, the breathing rate is normally about 12 to 15 breaths per minute, whereas an anxious patient may be breathing about 15 to 20 breaths per minute. Any rate of over 20 breaths per minute is considered to be abnormal for an adult. In healthy adults at altitude, elderly people, and patients with heart failure, a distinctive pattern of alternating periods of deep and shallow breathing can be seen. This is known as Cheyne-Stokes respiration, and is thought to represent an abnormal feedback from the carotid chemoreceptors in the respiratory centre. Last year, I spent some time at Everest Base Camp with my best friend and clinical partner who I've known since medical school. As our altitude decreased, so did our oxygen saturations, with mine personally dropping down below 80%, which was a little bit alarming for me.
Right, we're in our room. It's cold. I'm wearing a jacket designed for -15 in the room. The air is really thin. I'm really feeling the effects of the altitude. I feel like I've had a decent sized glass of wine. I haven't. Just knackered. Everything is exhausting. Walking up the stairs, I have to stop like an old person. Trying to think about what I need for tomorrow. My brain's running at like 1/8 of a mile an hour. It's just, you end up just looking at things going, that is a camera. I need to take that camera. They are socks. I need to wear those socks. And it's just everything's running super slow. James, I'm not sure how you're doing brain-wise.
I've just been doing some posts for the medical school, and for a perfect example, I couldn't write baseline. I wrote bench marker and then line of base, and it's like, this is just stupid. This really is. But we've just checked each other's SATs, and yours have come in at 80%, and mine have come in at 85. You know, they're not good SAT levels.
Learning points for all of you medical students out there. Oxygen, good. No oxygen, bad.
Okay, after that brief detour, let's return to the examination sequence. When inspecting the skin for any relevant abnormalities, subcutaneous metastases from lung tumours might be seen. As horrible as this may be, they do offer the chance for a rapid biopsy and diagnosis of an underlying problem. In the legs, painful dusky red lesions of erythema nodosum may indicate an underlying sarcoidosis, or swelling may signal a thromboembolic disease. After the overview of the patient, we want to get them to put their hands out in order to look if there is any peripheral stigmata of systemic disease. Looking over the hands and arms, finger clubbing is seen frequently, and this is due to an overgrowth of soft tissue in the terminal phalanx. This in turn will increase the lateral and longitudinal curvature of the nail and raising the nail bed off the underlying bone. When examining a patient with finger clubbing, there is a palpable fluctuation of the nail body against the bed when pressure is applied just proximal to the nail. There are multiple causes of clubbing which are vital revision at medical school, and we'll attempt to highlight those during the appropriate chapters. In terms of respiratory or thoracic cause for clubbing, these would be lung cancer, chronic suppurative conditions such as pulmonary tuberculosis, bronchiectasis, lung abscesses, empyema, and cystic fibrosis. Mesothelioma and fibromas, along with pulmonary fibrosis, are other causes of clubbing. It's vitally important to note that chronic obstructive pulmonary disease, COPD, is not a cause of clubbing. This is one of the commonest mistakes I see when doing assessments and asking people for thoracic or respiratory causes of clubbing. Clubbing itself is assessed for by getting the patient to put their nails together to see whether or not a diamond shape of light is still visible between the nails. This is Shamroth sign, again another of those wonderful medical phrases which I always feel sounds like a character from Lord of the Rings. If Shamroth sign is absent, then a patient has been determined to have clubbing. Any assessment of clubbing must include looking for Shamroth's window in order to be accurate about any clinical findings. The hands generally form an amazing window into the body. Additionally, a rare complication of lung cancer is hypertrophic pulmonary osteoarthropathy, in which painful, tender swellings of the wrists and ankles can accompany the pronounced finger clubbing. X-rays of the distal forearm and lower legs show subperiosteal new bone formation overlying the cortex of long bones. There are other important signs of respiratory disease which should be looked for in the hand, these being cyanosis, so the blue fingertips, tar staining of the fingers from tobacco. Note this is not from nicotine, as nicotine is a clear, colourless substance. Wasting of the small muscles of the hand, which may indicate a T1 nerve root damage by an apical lung tumour, and rare yellow-brown discoloration of the nails, as in yellow nail syndrome. Yellow nail syndrome is one of those exceptionally rare hen's teeth type diagnoses which you're taught about at medical school and will never ever see in the real world. But because it's mentioned here, I do think it's worthwhile highlighting what it actually is. Apart from a very rare medical condition, this is one where you have pleural effusions, lymphedema, and yellow dystrophic nails. Whilst it is a very rare condition, the fact that it is associated with chronic sinusitis and persistent coughing is one of the reasons why it should sometimes be kept in the minds of those people doing respiratory examinations. Similarly, it is also worthwhile noting that 40% of those people affected also have bronchiectasis. However, that does not mean that people who have bronchiectasis, 40% of them will develop yellow nail syndrome. After the superficial examination of the hands and arms, we need to continue on to get the patient to hold their arms out straight, with their wrists extended, to see whether or not there's any presence of a coarse tremor which is associated with CO2 retention. A fine tremor can be seen in the outstretched hands also in respiratory patients, and is usually due to the direct effect of high-dose beta-antagonist bronchodilators such as salbutamol on skeletal muscle. As I'm a bear of very little brain, I like to try and keep my clinical examinations in a straight line. What I mean by that is I will do the examination of the hands first, then checking the pulses at the wrist, and character, if needed, at the elbow, and thereupon doing the blood pressures. From there, stepping away from the Macleod's clinical examination protocol, I would then examine the neck before moving on to the face and then down to the chest. This means I'm less likely to forget things, but also it means that I don't end up apparently repeating examinations over the same area more than once. So with that in mind, we're now going to go over the neck sequence of examinations and then round backwards towards the face as is set out in Macleod's approach. Examining the neck on the respiratory patient. The jugular venous pressure is raised in many patients with pulmonary hypertension and may be acutely raised in those with a tension pneumothorax or large pulmonary embolism. In superior vena cava obstruction, the JVP may be raised above the angle of the jaw, making its pulsatility invisible. In those who are using the sternocleidomastoids as accessory muscles, it is frequently impossible to see the JVP, as the internal jugular lies deep within the active muscle. The JVP is best seen on the patient's right side. Here the patient should be positioned supine but reclined at 45 degrees with, as mentioned, the head resting on a pillow and the head turned slightly to the left. The JVP is seen best if the sternocleidomastoid muscle and the overlying skin are relaxed, so ensure the head is supported and avoid excessive head turning or elevation of the chin. Look across the patient's neck from the right side. Use oblique lighting if the JVP is difficult to see. You can identify the jugular vein pulsation behind the sternocleidomastoid muscle, and it's usually seen just above the clavicle, unless it is elevated. If pulsation is visualized, the abdominal jugular reflux test is used to help confirm that it is the JVP which is being observed. The JVP is the vertical height in centimetres between the upper limit of the venous pulsation and the sterno angle. This is found at the junction of the manubrium and the sternum at the level of the second costal cartilages. Identifying the timing and the waveform of the pulsation and the note of any abnormality can provide further clinical information. It can be difficult to differentiate the jugular venous waveform from arterial pulsation. If this is the case, the following might help. The hepatojugular reflux test, as mentioned, which can also be described as the abdominal jugular test. Here you press firmly over the abdomen. This increases venous return to the right side of the heart temporarily and also causes the JVP to rise in response. Changes in respiration. The JVP normally falls with inspiration due to the decreased intrathoracic pressure. Looking at the waveform of the JVP, as the normal JVP waveform has two distinct peaks per cardiac cycle. An A wave corresponding to the right atrial contraction and occurs just before the first heart sound. However, in atrial fibrillation, that A wave is absent. The V wave is caused by the atria filling during ventricular systole when the tricuspid valve is closed. Rarely, a third peak C wave can be seen due to closure of the tricuspid valve. In occlusion, the JVP waveform is obliterated by gently occluding the vein at the base of the neck. Here you should not be able to feel the pulse as opposed to when examining for the carotid artery, and is one of the easier ways to determine what it is that you are observing. Changes in patient position will also alter the JVP. With the patient supine, the jugular vein is distended and pulsation is not visible. At 45 degrees, the position where we should be examining the JVP, the point of transition between the distended and the collapsed vein can usually be seen just pulsating above the clavicle. And finally, when the patient is sat upright, the upper part of the vein is collapsed and the transition point is thus obscured. The JVP provides a guide to central venous pressure. It is elevated in states of fluid overload, particularly heart failure. We must examine the patient for pulmonary edema or pleural effusions, ascites and or peripheral edema. It's also elevated in any condition which leads to high right ventricular filling pressures, such as pulmonary embolism, chronic hypertension, cardiac tamponade, or pericardial constriction. Mechanical obstruction of the superior vena cava, most often caused by lung cancer, may cause extreme, non-pulsatile elevation of the JVP. In this case, the JVP no longer reflects right atrial pressure, and the abdominojugular test will be negative. Kussmaul's sign, a paradoxical rise of the JVP on inspiration, is seen in pericardial constriction, severe right ventricular failure, and restrictive cardiomyopathy. Prominent A waves are caused by delayed or restricted right ventricular filling, as in pulmonary hypertension or tricuspid stenosis. Giant A waves or cannon waves occur when the right atrium contracts against a closed tricuspid valve. Irregular cannon waves are seen in complete heart block and are due to atrioventricular dissociation. Regular cannon waves occur during junctional rhythms and with some ventricular and supraventricular tachycardias. Finally, tricuspid regurgitation results in a prominent systolic V wave which may fuse to the C wave, producing CV waves. These might be associated with a pulsatile liver as well. So to recap there, abnormalities of the jugular venous pulse would be heart failure, where the elevation would be seen along with the sustained abdominal jugular reflux of more than 10 seconds, pulmonary embolism causing simple elevation, pericardial effusion causing elevation and a prominent Y descent, pericardial constriction, again causing elevation and Kussmaul's sign, superior vena cava obstruction, here we have elevation and loss of pulsation, atrial fibrillation causing absent A waves, tricuspid stenosis with giant A waves, tricuspid regurgitation, giant V or CV waves, and finally complete heart block giving the cannon waves. Having assessed the JVP, we then need to check for tracheal deviation by gently advancing a single finger resting in the sternal notch in the midline. If the fingertip meets the centre of the trachea, it is not deviated. It's always worthwhile highlighting to the patient what you're about to do before you examine for tracheal deviation, as even slightly more pressure than is intended to be applied when pressed over the trachea can be particularly discomforting. If a particular examination or test is going to be uncomfortable for a patient, I think it's vital that you advise them of this beforehand. During an examination, we should do everything possible not to hurt the patient, or, if there is a likelihood of this happening, explain it to the patient beforehand. Checking the tracheal deviation is a really good example of how we should be doing this. Heck, if you don't believe me, just poke your own finger into your trachea at the base of the neck now, and you'll get an idea of how an unpleasant sensation it is. Hence, we really need to make sure that we are doing everything in our patient's best interests, and when they may come to harm or discomfort, we give them that shot across the bow before we continue on. This is particularly highlighted because we then need to check the cervical lymph nodes, which should be done from behind with the patient sitting forwards. Again, communication is vital at this point for you to explain to the patient, I'm going to examine your neck now from behind, and I'm going to put my hands on your neck and see if I can feel any lumps and bumps under the skin. Otherwise, the doctor steps behind the patient, out of the patient's field of view, and then suddenly from behind is grasped round the neck by two hands they weren't expecting. To expand on those points a little bit further, tracheal deviation will be away from the affected side, seen in things such as tension pneumothorax, where the expansion of air within the chest is pushing the trachea away from the affected side. Chronic tracheal deviation towards an affected side will occur when there is a loss of a lung volume in the upper lobe, such as due to fibrosis, collapse, or following a lobectomy or pneumonectomy. Another step in examining the neck is to check the cricosternal distance. This is the vertical distance between the sternal notch and the cricoid cartilage, the first prominent ridge felt above the tracheal rings. In a healthy patient, you normally have 3 fingers able to fit between the sternal notch and the cricoid. A reduction in the cricosternal distance is a sign of hyperinflation and reflects upward displacement of the sternum. Upward movement of the sternum and downward movement of the trachea on inspiration is normal, but may become more obvious with forceful inspiratory efforts in respiratory disease. Rarely, systolic downward movement of the trachea is felt in patients with aortic aneurysms and is sometimes called a tracheal tug, but this should not be mistaken or confused with the tracheal tug that is seen in respiratory distress in paediatric patients. The final part of assessing the neck involves looking at the cervical lymph nodes. The assessment of both the cervical and the axillary lymph nodes are both performed with the patient sitting. However, the cervical lymph nodes are performed from behind the patient. At the same time, we'll also examine for submental lymph nodes, submandibular lymph nodes, preauricular, tonsillar, supraclavicular, and the deep cervical lymph nodes in the anterior triangle of the neck. We would palpate for scalene lymph nodes by placing your index finger between the sternocleidomastoid muscle and the clavicle, asking the patient to tilt their head to the same side and pressing down firmly towards the first rib. In terms of examining for supraclavicular lymph nodes, this will be done getting the patient to shrug their shoulders upwards. Continuing in my examination approach of following a straight line around the body, after having assessed the neck, we would then move on to look at the patient's face. Respiratory disease can cause important signs in the face. The superior vena cava obstruction causes a dusky, generalized swelling to the head and neck with subconjunctival edema. This is usually a very worrying sign as it can indicate tumour invasion of the upper mediastinum. A tumour at the root of the neck may also disrupt the sympathetic nerves to the eye, which run from the upper thoracic spinal segments via ganglia in the neck to join the carotid artery sheath. This causes unilateral ptosis and pupillary constriction, also known as Horner's syndrome, and again is one of the rare conditions you will always check for and almost, thankfully, never come across. However, over time, all of these small, little signs that you are looking for do become embedded in your clinical examinations in the same way that the classic mirror signal manoeuvre becomes embedded in your day-to-day driving habits after you have passed your driving test. Following completion of the examination of the neck, it would now be appropriate to get the patient to fully undress their upper torso. Here, again, providing an inspection of the patient visually to comment on any abnormalities that may have been missed previously on the end of the bed examination. After the overview of the patient, whereupon we'd expect abnormalities of the chest wall, any scars, or any obvious distress or evidence of intercostal recession to be highlighted, we'd move on to performing the palpation. The first step on palpation in the respiratory exam involves locating the apex beat. This is the most inferior and lateral place where the finger is lifted and twisted by systolic movement of the cardiac apex. This is normally in the fifth intercostal space, mid-clavicular line, and can be found by counting down the intercostal spaces from the second, which is just below the sternal angle. We need to palpate for the right ventricular heave using a straight arm with the palm over the sternum. The apex beat is displaced laterally by dilation of the ventricles or leftward displacement of the mediastinum. Hyperventilation in obstructive lung diseases causes the lingula of the left upper lobe to come between the heart and the chest wall, making the apex beat impalpable and the heart sounds inaudible. In this situation, heart sounds are best heard in the epigastrium. In pulmonary hypertension, the lower sternum is lifted by the cardiac cycle due to a right ventricular heave. After pressing on the chest in this way, we next need to assess thoracic expansion both in the upper and lower anterior chest wall. Cup your hands with your fingers spread around the patient's upper anterior chest wall, whilst pressing the fingertips firmly into the mid-axillary line. Pull your hands medially towards each other to tighten any loose skin, and use your thumbs, off the skin, as pointers to judge how much each hand moves outwards when the patient is instructed to take a full breath. In a healthy thorax, the ribs move out and up with inspiration. When doing this, we need to check for any asymmetry. This is more important than the absolute degree of expansion, which will vary between individuals. Then repeat the process in the lower anterior chest wall. In COPD with hyperinflation, the normal outward movement of the lower ribs on inspiration is replaced by paradoxical inward movement caused by contraction of the abnormally low, flat diaphragm. This striking sign, paradoxical ribcage movement, or Hoover's sign, may be missed if expansion is assessed only in the upper chest or from behind. Palpation of the chest wall may rarely reveal surgical emphysema, which indicates air trapped in the subcutaneous tissues. This is most commonly seen in complications from pneumothorax with a chest drain or rib fracture, and feels like palpable crackling under the skin of the upper thorax and neck. Personally, surgical emphysema is one of those light bulb moments, both at medical school and as a doctor. You learn about it, you understand that it's where air gets trapped under the skin, a little bit like bubble wrap, but it's not until you actually come across it the first time that you fully understand exactly what this means. And as daft as it is to say it, it sounds as people describe it. You put your hands on a patient's skin and you can feel it crackling and popping underneath your fingers as you can feel the small bubbles of air there. It really is quite a bizarre thing, but once seen, never ever forgotten. With palpation completed, we then move on to percussion. This is one area that medical students frequently find it very difficult to understand and become proficient in during clinical teaching. The main reason there being that these areas are quite loud actually, and I advise that the best learning environment initially is going to be at home in the quiet, where you can percuss over your own chest or that of a friend and hear exactly what it is that's going on with regard to the sound waves travelling through the tissues. Correctly performed, percussion can distinguish areas of the chest wall over air-filled lung from those overlying consolidated lungs or fluid. It generates a hollow, ringing sound accompanied by a palpable resonance over an air-filled lung, but a dull thud lacking of resonance over an area of consolidation or fluid. The absolute quality and volume of the percussed sound varies widely between individuals with differing chest wall thicknesses, muscularity, and subcutaneous fat, and thus is of little value. The value of percussion lies in detecting asymmetry of resonance between the mirror image positions on the right and left sides of an individual person. To correctly percuss the chest, apply the middle finger of your non-dominant hand firmly to an intercostal space parallel to the ribs and drum the middle phalanx with the flexed tip of your dominant index or middle finger. Percuss in sequence, comparing areas on the right with corresponding areas on the left before moving to the next level. Posteriorly, the scapula and the spinal muscles obstruct percussion, so position the patient sitting forwards with their arms folded across their chests to move the scapula laterally. Percuss a few centimetres lateral to the spinal muscles, taking care to position the same distance from the midline on the right and on the left. In healthy people, anterior chest percussion is symmetrical except for the area immediately lateral to the lower left sternal edge, where the right ventricle causes dullness. This cardiac dullness is lost in hyperinflated patients in whom the lingula overrides the heart. Clear resonance is the usual finding over a pneumothorax, although the difference between the normal lung and a pneumothorax may be quite subtle, as the normal lung is almost all air. Resonance on percussion together with unilateral absent breath sounds indicates a pneumothorax. Having dealt with palpation and percussion, the next step would be auscultation. To understand chest auscultation, it is necessary to understand the origin of the breath sounds. The tracheobronchial tree branches 23 times between the trachea and the alveoli. This results in an exponential rise in the number of airways and their combined cross-sectional area as we move towards the alveoli. During a maximal breath in and breath out, the same vital capacity, about 5 litres of air in a healthy adult, passes through each generational airway. In the larynx or trachea, this volume must pass all through a cross-sectional area of only a few square centimetres, and thus the flow rate is fast, causing turbulence with vibration of the airway, generating the breathing sounds. In the distal airway, the very large total cross-sectional area, with the multitude of bronchioles, means that 5 litres can easily pass at slow flow rates. So flow is normally virtually silent in these larger airways. You can hear a good example of bronchial breathing at home if you grab a stethoscope and put it over your neck, specifically over the larynx, then breathing slowly in and slowly out. This hollow breathing sound is what we term bronchial breathing if we'd heard it when listening to a patient's chest. Most of the sound heard when auscultating the chest wall originates in the large central airways, but is muffled and deadened by the passage through the overlying air-filled alveolar tissue. This, together with a small contribution from the medium-sized airways, results in normal breath sounds at the chest wall, sometimes termed vesicular breathing. When a healthy, air-filled lung becomes consolidated by pneumonia or thickened and stiffened by fibrosis, sound conduction is improved, and the centrally generated bronchial breath sounds appear clearly and loudly over the overlying chest wall. This is why if you take your stethoscope and listen to your own chest wall, the breathing will sound very different from that hollow breath, that bronchial breathing you get when you listen over your own larynx. In the same way, with soft speech, saying 1, 2, 1, 2, the laryngeal sounds are muffled by a healthy lung, but heard clearly and loudly at the chest wall overlying consolidation and or fibrosis. This is due to improved conduction of the major airway sounds through this diseased lung. When there is a lobar collapse caused by proximal bronchial obstruction, for example by a tumour, the sounds are different from those in simple consolidation. The usual findings are diminished on expansion, sometimes with chest asymmetry due to volume loss, dullness to percussion over the collapsed lobe, and reduced breath sounds and vocal resonance. When the lung tissue is physically separated from the chest wall by intervening air, such as with a pneumothorax, or fluid, if we have a pleural effusion, the sound conduction is greatly impaired. Thus, the breath sounds are usually absent. These two causes of absent sounds are readily distinguished by percussion, which will be resonant with a pneumothorax and completely dull over a pleural fluid. I've always found two very good examples that helped clarify this in my head. If you've got a friend who's snorkeling in a pool and you try and shout from the poolside to get their attention, they won't hear you at all because the sound waves will not travel from the air into the water. The same is true if we have a pleural effusion. Sound won't travel easily from the air through the fluid, and thus we lose breath sounds. Conversely, if you have consolidation, then you get increased transmission of the major airway sounds because of the ability for the sound to be transmitted through the solid. A good example of this would be the classic child's toy, the tin can telephones, whereupon you have two tin cans joined by a piece of string. When the string is taut, you get good transmission of the sound from one tin can to the other, in the same way as we get with consolidated lungs. With this in mind, let's have a little bit of a closer look into using the stethoscope. Remember to wear the stethoscope with the earpieces facing forwards to align them with your auditory canal. Normal breath sounds are relatively quiet, so the greater air of conduction offered by the diaphragm is usually well adapted to chest auscultation. Two common exceptions are in patients with a cachectic chest wall where they have sunken intercostal spaces. Here, it may be impossible to achieve flat skin contact with the diaphragm. Similarly, a hairy chest wall, where movement of the chest hairs against the diaphragm can be easily mistaken for lung crackles. In these situations, use the stethoscope bell instead to hear breath sounds. Let's talk a little bit more about those breath sounds. As with percussion, the absolute volume and character of the breath sounds in individuals is greatly affected by the thickness, muscularity, and fat content of the chest wall. The symmetry of the sounds is therefore again the key feature. When doing the auscultation examination, auscultate the apices comparing the left and right, and changing to the bell if you're not able to achieve flat skin contact with the diaphragm at the very top of the lung. Ask the patient to take repeated, slow, deep breaths in and out through their open mouth. Auscultate the anterior chest wall from the top to the bottom, always comparing mirror image positions on the right before moving down to the left. Use the same sequence of sights as for percussion. Don't waste time by listening to repeated breath cycles at each position unless you suspect an abnormality and wish to check. Frequently, I will find that I will perform a normal examination, looking at all the areas on the chest, but will keep going back to compare one area with the other repeatedly, sometimes spending up to a minute or two comparing these areas if I can think I can hear a difference in the two sides, but I'm not completely sure. In terms of reporting the breath sounds, you need to note whether the breath sounds are soft and muffled, absent, or loud and harsh, bronchial like those over the larynx. Seek and note any asymmetry and added sounds before deciding which is the abnormal side. Auscultate the lateral chest wall in the mid-axillary line, and again comparing the right with the left before changing levels. Now we need to talk about the added sounds we may come across. There are three common added sounds: wheezes, crackles, and rubs. A wheeze is a musical whistling sound, accompanying airflow and usually originates in narrowed small airways. It's most commonly in expiration due to dynamic airway narrowing on expiration, but can also occur on inspiration. Usually, multiple wheezing sounds are heard together, this being termed a polyphonic wheeze. This is a common sign in asthma, bronchitis, and exacerbations of COPD. A solitary wheeze that is present consistently with each breath and does not clear on coughing suggests a possible fixed bronchial obstruction and can be an important sign of an underlying cancer. Crackles, accompanying deep breathing, are thought to represent the sudden opening of small airways, but sometimes may indicate secretions in the airways or underlying lung fibrosis. In healthy people, gravitational compression of the dependent lung bases often causes a few crackles in the first few deep breaths, but these are of no pathological significance as long as they clear. Crackles that persist after several breaths and do not clear with a deliberate cough are considered pathological. Crackles found on auscultation are graded as fine, meaning soft multiple crackles, through to coarse, indicating loud, scanty crackles that tend to change with each breath. Showers of fine crackles during inspiration, resembling the sound made by peeling a Velcro fastener, are characteristic of interstitial pulmonary fibrosis, and are most commonly heard at the lung bases posteriorly and laterally. Fine crackles also occur in pulmonary edema and some viral pneumonias. Coarse crackles are generally heard in patients with significant purulent airway secretions, such as those with bronchopneumonia or bronchiectasis. Inspiratory crackles are also heard over areas of incompletely inflated lung, immediately above a pleural effusion. A pleural rub is a rasping, grating sound occurring with each breath and sounding superficial just under the stethoscope. Some may describe it as two sheets of sandpaper rubbing together. However, I personally prefer to describe it as the sound you get when walking on fresh snow. Certainly, once you've paid attention to the sound you get walking on fresh snow, almost a squeak, when you next hear a pleural rub, you will not be able to think of fresh snow in the same way again. This can indicate a pleural inflammation and is usually due to infection and is often accompanied by pleuritic chest pain, i.e. a pain on deep inspiration. Vocal resonance. Breath sounds normally reveal the presence of consolidation or fibrosis, that being bronchial breath sounds, or pleural air or fluid, where we'll have absent breath sounds. These sounds can be confirmed by asking the patient to generate laryngeal sounds deliberately. Please say 1, 1, 1 each time I move my stethoscope on the skin, and listening on the chest wall in the same sequence of sights and used for breath sounds. The spoken sound is muffled and deadened over healthy lung, but the spoken sound is heard loudly and clearly through the stethoscope over consolidation or fibrotic lung scarring. Consistent with absent breath sounds, vocal resonance is absent or greatly diminished over a pneumothorax or a pleural effusion. Whispering Pectoriloquy is used to confirm the same changes with sound conduction. There, whispered speech is muffled to silence by the normal lung, but may be heard over a consolidated or scarred lung. At this point, I'd like to just deviate slightly into James's random pathology. Classically at medical school, people have been taught to use the phrase 99 rather than 1, 1 or 1, 2. The reason being is that vocal resonance was determined by a German physician, and over there, 99 is actually 9 or 90, so is a diphthong, and has a different characteristic of sound patterns passing through the chest wall compared to 99. Thus, in order to assess vocal resonance correctly, we should be using an appropriate diphthong such as 1-1 or 1-2, and not the flawed 99 as classically taught. Upon completing your examination, you would want to review your findings and assemble the positive features which you've uncovered. Combining these with the history, you should have a broad idea of the category of respiratory illness you're dealing with, and from there would be able to comment on the most appropriate investigations and management plan. Selecting the relevant investigation depends on the clinical problem revealed in the history and examination. Investigations are costly and may carry risk to the patient, so choose tests capable of distinguishing the likely diagnosis and prioritise the most decisive ones. In respiratory disease, imaging the lungs is fundamental, but respiratory function testing is equally important to distinguish obstructive disease of the airways from restrictive patterns which may be seen in parenchymal diseases, and to quantify the degree of abnormality. This pretty much wraps up our overview of the respiratory examination. However, I think it would be worthwhile just to go through a quick recap of some conditions and what features we may find. If we were dealing with an infection, such as acute bronchitis, pneumonia, or an exacerbation of COPD, in the history, the patient might comment of fevers, a wheeze, cough, be that productive or otherwise, and acute and chronic shortness of breath. They may describe a pleuritic chest pain when they take a deep breath in, getting pain, maybe have rusty sputum, and may also complain of rigors, a cold shaking associated with a fever. On examination in these patients, we'd expect to find hyperinflation, a lobar, if dull percussion note, and bronchial breathing, along with potentially a wheeze. If we were concerned that a patient might have a malignancy, on our history they would probably comment of insidious onset of symptoms, unexpected weight loss, and persisting pain or a cough. On examination, we'd likely find hard, non-tender cervical lymphadenopathy, clubbing, signs of lobar or lung collapse, and potentially the presence of an effusion. If we were considering pulmonary fibrosis based on a patient's occupation history, we may find that their only symptom is a progressive dyspnea or shortness of breath. Whereas on examination, we might find tachypnea, so increased breathing over 20 resps per minute, inspiratory fine crackles at the bases, and potentially cyanosis. A pleural effusion may also present with simple progressive dyspnea. Here we would find unilateral basal dullness and reduced breath sounds. A worrying differential would be pulmonary embolism. These may be large, medium, or multiple small emboli. This can have a sudden onset of pain and severe shortness of breath. The pain may be described as pleural, whereupon the pain is on deep inspiration. The patient may comment of hemoptysis, the coughing up of blood, and progressive dyspnea as the emboli worsen. On examination, we're likely to have normal breath sounds, a pleural rub, a swollen leg if this has come from a DVT or deep vein thrombosis. There may also be heard crackles if part of the lung has infarcted and died. Raised jugular venous pressure and a right ventricular heave may also be found, along with a loud pulmonary second sound. In a patient presenting with asthma, they may have a history of atopy, hay fever, they may have recently acquired a new pet, there might be a variable wheeze, and there will most likely be a disturbance of sleep. On examination, we'd expect to find a polyphonic expiratory wheeze and possibly eczema when reviewing the patient from the end of the bed. I hope this has been a useful overview of the respiratory examination and has been of benefit for those revising their exams. I'd be really grateful if you have found a benefit here for you to like and subscribe to the channel, because that kind of confirms things through metrics, but also if you've got any comments about how we can improve these videos, given this is the first one where we've actually overlaid the examination in video form. I'd be really grateful for your feedback. Many thanks and hope to see you on the next one. Take care. Bye.